Hello everyone. Today we'll be talking about more complex acid-base problems. We'll discuss about chronic compensation as they add a layer of complexity to your baseline ABG interpretation. In these cases, bicarb and carbon dioxide levels are not normal. So if you're not careful, you can draw wrong conclusions. In this lecture, we'll examine what kind of challenges do chronic compensation brings us. Please go ahead and review my earlier two lectures on ABG and get comfortable with the concepts before proceeding. So let's start with an example. We have a COPD patient with chronic CO2 retention. His baseline PaCO2 is 60 and he's compensating renally with bicarb of 36, pH is 7.4. Let's say he develops COPD exacerbation and starts retaining CO2. His CO2 is now 95. His pH has dropped to 7.2 and he has some acute metabolic compensation for this respiratory problems. So his bicarb is up to 38 from 36. So patient just has acute respiratory acidosis and acute metabolic compensation for this. But if we don't have the baseline understanding of the bicarb and PCO2, we can draw wrong conclusions. Going through 5 steps of ABG, the first 2 steps tells us that it's respiratory acidosis. In compensation, the compensation for respiratory acidosis is metabolic alkalosis. So if you take the acute compensation, well, your expected bicarb is going to be 29. Since his anion gap is normal at 12, his bicarb should be around 24, but the patient bicarb is 38, so he has gained 14 bicarb from somewhere else. Out of these 14, 5 have come from acute metabolic compensation for respiratory acidosis, so he must have gained 9 other from some other acute metabolic alkalosis process. So you would interpret this ABG as acute respiratory acidosis with acute metabolic compensation and acute metabolic alkalosis. Since patient has COPD and maybe he retains CO2, let's try to use chronic compensation to see where we end up. If we use chronic compensation, where the bicarb increases by 6 for every 10 rise in PCO2, your expected bicarb is now 54. And since you have gained 14 bicarb from somewhere else, you in fact had gained 30 bicarb from chronic metabolic compensation of respiratory acidosis. So you must have lost 16 bicarb somewhere else. So you must have acute non-anion gap metabolic acidosis on top of your respiratory acidosis. So you can see the limitation of this method in patients who are chronically compensated because they do not start at your normal PCO2 of 40 and bicarb of 24. This is usually a problem for metabolic compensation for respiratory issues, as there is both an acute and chronic compensation. However, for metabolic issues, there is only one respiratory compensation, so this problem is usually not seen. So let's understand limitation of ABG interpretation in patients with chronic compensation. For example, let's take a 30-year-old obese patient with BMI 50 with OSA and OHS and has got diabetes type 1. Let's say his baseline PaCO2 is 60 and we know that change of 0.1 of pH is brought down by 10 of CO2. So your pH must be around 7.2 and therefore your kidneys will compensate and they will increase the bicarb to make your pH normal. So this patient baseline ABG would look like pH of around 7.4, bicarb of 36 and PCO2 of 60. So let's analyze some of the problem with the ABG when you are interpreting in patient with chronic compensation, and we'll use this patient as the example. So let's say this patient develops diabetic ketoacidosis. His bicarb has dropped from 36 to 30 and his pH has dropped from 7.39 to 7.30. So he will breathe faster and will blow out CO2 and his PCO2 is now 51 and that has brought the pH up to 7.38. So this patient has got metabolic acidosis from decay and his lungs have responded appropriately with increased minute ventilation and has normalized the pH. But if you go through the first 2 steps of ABG interpretation in this case, it would really appear that this patient primary process is respiratory acidosis as your pH is less than 7.4 and PCO2 is more than 40. So you can already see that unless you know the baseline PCO2, you may make an error in finding the primary process. Let's look at the compensatory phase. Let's say this patient took some morphine for leg pain and started retaining more CO2. His CO2 level went from 60 to 70. 60 of PCO2 is his baseline, but this is a chronic compensation phase from 40. So if you really want to calculate the compensation, you have to calculate both the phases, both acute and chronic compensation. So this patient, the chronic compensation was increase of PCO2 from 40 to 60. That means your expected bicarb would be 36 because your bicarb should rise by 6 for every 10, and we have here rise of PCO2 by 20. And in acute phase, your PCO2 has risen by 10, so your bicarb should increase only by 1. So your expected bicarb should be 1 on top of 36, so 37. So you can see that there is both acute and chronic compensation happening simultaneously in this patient. But the question always remains is, if you don't know the baseline, how do you know which one contributes to what extent? So for example, if you do not know the baseline, you would have assumed the baseline PCO2 is 40, and if you calculated the compensation using acute formula, your expected bicarb should be 27, and since his bicarb is 37, you would assume that he is getting 10 bicarb from somewhere else, so he has acute metabolic alkalosis. Or if you use just the chronic formula, your expected bicarb would be coming at 42, so you would assume that he is losing 5 bicarb from somewhere, so he has acute non-iron gap metabolic acidosis. So it is important to figure out what the baseline PaCO2 and bicarb of these chronic compensating patients are. Step 4 is finding anion gap, and fortunately this is independent of all other steps, so there is no problem with step 4. You can figure out anion gap independently of all other steps. Step 5 depends upon step 3 for its interpretation. So if there is an error in compensation, this will be reflected in the bicarb gap. So for example, in this case, if you use acute compensation, your expected bicarb comes out to be 25, and since his measured bicarb is 30, so he has gained 11 bicarb from somewhere else, and since he only got 1 from the acute compensation, rest 10 must have come from acute metabolic alkalosis, not from respiratory compensation. If you took the chronic compensation, your expected bicarb would be 36, and here, since he gained 11 bicarb from somewhere else, and since he has gained 12 bicarb from the compensation, that tells you that the bicarb difference is mostly from this acute metabolic compensation for respiratory acidosis, and there is no other process going on. So it is important to understand what kind of chronic compensation is going on with the patient. Commonest compensation problems are seen in patients with chronic respiratory acidosis where patient retains CO2. For example, patients with advanced COPD, hyperventilation syndrome, neuromuscular weakness, etc. You typically don't have chronic respiratory alkalosis problem unless you live in mountains. The second commonest compensation seen in patient is chronic diuretic use, where it causes chronic metabolic alkalosis, where patient lose a lot of chloride in their urine. And in patients with CKD and ESRD patient, they can have chronic metabolic acidosis. Fortunately, for the metabolic processes, the compensation has only one formula, so you don't have to worry about acute or chronic components. So now you understood the problem. We'll discuss how we can get around it in the next lecture. The most important thing to know is knowing baseline is the most critical part of ABG interpretation, and this is the part where most of the providers get the things wrong. Thank you.